Good afternoon, everyone. Today, I'm going to present my group discussion on the topic clozapine. This is a very important drug both for theory and in practically in our words. So, and what are antipsychotics? Antipsychotics are any class of therapeutic drugs that are used to treat psychosis. Broadly, they are divided into first generation and second generation antipsychotics, as we all know the examples. So, second generation antipsychotics were first introduced in the 1990s. Currently, they are more commonly prescribed than the first generation ones. The clozapine was the first second generation antipsychotic to be discovered, and initially it was called atypical antipsychotic because the first generation antipsychotics that were used earlier, the most common side effect that they produced was EPS. And when the first second generation antipsychotic clozapine was discovered, the very atypical feature was saying that it did not cause any EPS, so that name was given to clozapine. In 1958, initially it was first studied in animal experiments, and it was started in 1972 in Europe. But soon it was discovered that it caused a lot of hematological toxicity. Neutropenia was present, and agranulocytosis was seen, and it was discontinued soon after that. In Finland, it was seen that out of 1,600 patients, 16 developed granulocytopenia, and out of the 13 had such a severe granulocytopenia that it died of infectious diseases. So clozapine for some amount of time was stopped in Europe, but eventually it was seen that there are some patients, a group of patients who are very treatment resistant, and no first generation second generation antipsychotic, when it doesn't work, clozapine always shows results. So it was restarted, and the first indication that was given at that point of time was treatment resistant schizophrenia. Clozapine has to be given. In 1988, it was compared in a study by Herbert Melzer. It was compared with chlorpromazine, and on many important points, it proved to be better than chlorpromazine, including psychosis, mood, and anxiety. And in 1990, it was approved in USA. Initially for treatment for schizophrenia, patients of schizophrenia which were resistant to other antipsychotic drugs, and those who had excessive extrapyramidal effects or severe tardive dyskinesia on the conventional antipsychotics. Initially, it was seen that clozapine could replace the other second generation antipsychotics because it did not have any EPS. But eventually, we saw that clozapine is not as commonly used, only used in treatment-resistant schizophrenia because of its a special set of side effects that we will see later. But in KT trials, in phase 2E of the KT trials, it was seen that clozapine is probably the most effective antipsychotic when it comes to controlling the positive symptoms. So, some theoretical point that clozapine is a five-membered heterocyclic compound with a molecular weight of 326.8. Some other clozapine-derived antipsychotics are olanzapine and quetiapine, but the efficacy is not similar, and the side effect profile is also a little bit different. Clozapine is available as an oral preparation, and as with other antipsychotics, it reaches its peak plasma level 2 hours after the administration. The half-life is approximately 12 hours. That is why clozapine, as we see in the words, is given in a twice daily usage because of its 12-hour half-life. And it takes about 1 week to reach steady-state plasma concentrations. That is, if you slowly titrate it from a lower dose. And most of the adverse effects are dose-dependent, and that's why we titrate from lower doses. We see if any side effects are occurring at a lower dose, then we increase gradually. So adverse effects are also more common at the beginning of the therapy. The clozapine undergoes a lot of first-pass metabolism in liver and gut. The bioavailability varies from 27 to 47%. The most common metabolic route is demethylation and oxidation of the aromatic ring and conjugation. 80% of clozapine appears in urine or feces as metabolites, and 5% is found unchanged in urine. Now, for special populations, for elderly, we need to decrease the dosage. For in renal impairment, we do not need to any change in the dosage of clozapine. For hepatic impairment, we also need to decrease the dosage, as we have read earlier. Hepatic first class metabolism, clozapine undergoes. And in CYP2D6, if person is poor metabolizer, we need to decrease dosage. We will read about drug interactions later on in the presentation. So in pharmacodynamics, the clozapine causes significantly less extrapyramidal side effects, which makes it different from other conventional antipsychotics. Most commonly, the extrapyramidal side effects are a result of the D2 receptor blockade. When we compare it with haloperidol, with 10 milligram doses of haloperidol, more than 80% of the striatal D2 receptors are occupied. But in clozapine, when it gives the same effect, only 40 to 50% of receptors are occupied with the same antipsychotic effect as haloperidol. This low affinity for D2 receptors can explain clozapine's lack of EPS. Uh, Also, clozapine's antagonism of 5-HT2 receptor is stronger than the other conventional antipsychotics. So it is proposed that this ratio of its low D2 antagonism and higher FHT2 and 5-HT2 antagonism, this ratio is responsible for its decreased EPS. Also, we see that clozapine has a higher affinity for D4 receptor. And D4 receptor is mostly present in the cortex and less in the striatal areas. Cortex is so the presence of D4 receptor in the cortex is from where most of the positive symptoms occur. When the clozapine blocks the D4 receptors better than the other antipsychotics, that's how it reduces the positive symptoms better than the other antipsychotics. Another hypothesis is that it has a preference for the mesolimbic dopamine system and less so for the nigrostriatal pathway. We know about the four dopamine pathways, and nigrostriatal pathway is the one which is responsible for the EPS. As clozapine is has a more selective preference for mesolimbic system and less for the nigrostriatal pathway. That's also another reason that it causes the decreased EPS. The most common metabolite, the N-desmethylclozapine, also has M agonist activity. Studies have suggested that the patients which have better clinical outcomes also have a higher concentration of N-desmethylclozapine. So a hypothesis is also present that the M1 agonism of clozapine can also be the reason for its better effects, better antipsychotic effects. Earlier we had read that compared to haloperidol, it occupies less D2 receptors. Not only it occupies less D2 receptors, but the receptors that it occupies, there is also a faster dissociation from that receptor. So it occupies that receptor for a less period of time. It occupies less number of receptors and those receptors for a less period of time. That also, once again, helps in causing less EPS. In the presence of dopamine, when the on the same receptor clozapine is there and the in presence of dopamine, it once again loosely comes off the receptor faster than the other conventional antipsychotics. But this is also seen with all second generation antipsychotics. Now, women and smokers have a slightly lower plasma level. Uh, that's why uh, that's why the effective women have slightly higher plasma level and smoker has slightly lower plasma level. That's why for women a less effective dosage is enough to cause a higher effect. And for smokers, as we will see later in most of the guidelines, it is also given that for smokers we need to increase 20 to 30% dosage because they have a lesser plasma concentration. The plasma concentration of clozapine should be 10 to 80 nanogram per ml per mg of drug given per kilogram of body weight. That means that a typical dosage of 300 to 400 milligram at an average is required. Approximately, we can say 5 milligram per kg for the effective plasma concentrations. So, as per Maudsley guidelines, for this is for the inpatient, the patient in the ward. The target dose for female non-smokers, as you've seen earlier, the females, the dose is higher, plasma concentrations are higher than what is given. So female non-smokers, our target should be 250 milligrams per day. So for female non-smokers, the target should be 250 milligram per day. For male non-smokers, the target should be 350 milligram per day. And as an example, if we take female smokers, we need we need to give a higher amount, 450 milligram per day. So initially, as we seen earlier, that the many side effects are dose dependent, and most of them tend to occur early in the treatment. So the first dose we usually give at night, and as per the guidelines, we should start with a 12.5 milligram dose. For the first 7 days, a very cautious dose increment is done. Initially, 12.5 milligram bedtime dose is given. Then we start with 12.5 milligram twice a day, and initially increase it once every day or every 2 days. After 1 week, we can increase the dose further by 25 to 50 milligram per day. And after 2 weeks, the increments can be 50 milligram weekly. So at that way, by day 28 or by 4 weeks, we can reach our target concentration of clozapine as per the guidelines. For an outpatient, on OPD basis, the increments have to be even more slowly and even more cautious. And whenever the person comes for follow up, we need to monitor the basic blood investigations, the blood pressure, and monitor for other side effects that we see with clozapine. If there is a break in the treatment, uh, we need to first monitor if there is any symptoms for cholinergic rebound, such as nausea, vomiting, diarrhea, sweating, headache, or any emergence of dystonias, dyskinesias, catatonic symptoms. Many times we give clozapine as a treatment for tardive dyskinesia, and in that person there can be a rebound dyskinesias. If the clozapine treatment is missed for more than 48 hours, we need to start retitration once again from a 12.5 milligram dose. So the indications for clozapine, the the first indication and the biggest indication is treatment in refractory schizophrenia, as we see most commonly in our wards. The FDA did a study comparing clozapine and chlorpromazine plus benztropine. Out of the 268 patients who participated in this trial, at least 3 prior antipsychotic trials were done, and a prospective blind trial for haloperidol was done. During this trial, the clozapine did much better than chlorpromazine on both positive as well as negative symptoms. On 14 out of 8 points of the brief psychiatric rating scales and as well as on clinical global impression scale, clozapine proved to be better for people who had resistance to the prior antipsychotics. Tardive dyskinesia, clozapine can be given in patients with tardive dyskinesia who develop on tardive dyskinesia on the regular antipsychotics. Uh, Clozapine is known to suppress abnormal movements in tardive dyskinesia, and it is less likely to cause the disorder. For patients with psychosis who have developed this problem, we can give clozapine, as we have a case in our ward also who was started on clozapine 2 years earlier, mainly because she started developing TD. And clozapine also preferred for patients of schizophrenia who are at a higher risk for suicide. It is known to cause, out of all the antipsychotics, the highest reduction in the rates of suicide in patients of schizophrenia. It is effective in delaying the time to recurrent suicidal behavior. Now, the precautions and the adverse side effects. Now, as per the comprehensive textbook of psychiatry, these are the contradictions to the clozapine use. First we need to see the obvious contradiction is the hypersensitivity to clozapine or any tablet compounds. If there is any early history of hypersensitivity, we cannot give clozapine again. We need to do basic blood investigations, and any WBC count, total leukocyte count, below 3,500 cells per mm cube. We need to first monitor the WBC count till it rises above this value to start clozapine. Any bone marrow disorder, because of the bone marrow suppression that clozapine causes, we cannot give clozapine. Any history of agranulocytosis during any previous clozapine treatment, cannot restart clozapine. Any concomitant use of any other known bone marrow suppression drug such as carbamazepine. CT. So starting with system-wise with the side effects of clozapine, the hematological and the cardiac side effects. It is known to be a cardiotoxic drug, but if we compare the overall mortality in schizophrenia from all the factors, overall mortality it still reduces in the patient of schizophrenia, largely because of the rate of suicide that it decreases. It is known to cause, out of the cardiac and the hematological side effects, very commonly known to cause agranulocytosis, thromboembolism, cardiomyopathy, and myocarditis. Agranulocytosis is the best known side effect of uh, clozapine, which is seen in 0.4% of clozapine patients. The incidence of death related to agranulocytosis following clozapine is 0.013%. Myocarditis in clozapine is a hypersensitivity in response to clozapine, which causes the inflammation of myocardium. It is potentially fatal with a case fatality rate of 12.7% and is most likely to occur in the first 6 to 8 weeks of starting clozapine, but it can occur at any time. It is diagnosed by echocardiography and to establish the left ventricular dilation, and a reduced ejection fraction is seen in the echo. Uh, it, if clozapine is not stopped, there are other factors in clozapine, like clozapine causes a sedentary lifestyle that may develop, a person may develop obesity, diabetes, and the persistent tachycardia that clozapine causes. These factors also contribute towards myocarditis and cardiomyopathy. The some symptoms that we can be aware of in patients with clozapine is hypotension, tachycardia, fever, flu-like symptoms, and dyspnea that we should be aware of in a person who is using clozapine. This person might be at a risk for cardiomyopathy. Some ECG signs like ST depression or any enlarged heart on radiography, echo, and eosinophilia. They, these symptoms can also develop in myocarditis. We should be aware of these symptoms when the person is started clozapine. Any risk, any sign of heart failure, immediately we should refer to a cardiologist and stop clozapine. Orthostatic hypotension is very commonly seen with clozapine, most probably in the starting of the treatment and when the dose is being incremented in the first couple of weeks. Orthostatic hypertension will be so severe that it can possibly cause syncope. Uh, Many times we start for a patient that is violent or very agitated. We start use with benzodiazepines, clozapine with a benzodiazepine that can also contribute to a syncope or a decrease in blood pressure and orthostatic hypotension. So it should be done cautiously, and constant monitoring should be done for hypotension. Tachycardia is the most common side effect that even in our wards that we see, the blood pressure, the pulse rate for a patient who is started on clozapine increases. Mostly it is around 100, above 100, sometimes touches 120. It is a direct effect of the vagolytic properties of the drug, and it is also present in the supine position. So it is not directly related to the orthostatic hypotension, the mechanism of orthostatic hypotension that it causes. The pulse rate is usually increased by 20 to 25 beats per minute, and when it is mostly seen when the clozapine dosage reaches 300 milligram per day over a 7-day period. The tachycardia should be, as per the guidelines, should be treated with a beta blocker such as atenolol. The propranolol, we prescribe propranolol here, but propranolol also itself carries a risk for agranulocytosis, and clozapine also carries a risk for agranulocytosis. So as per the guidelines, propranolol should not be given. Atenolol is a better option. There is a risk of fatal pulmonary embolism in about 1 in 4,500 patients, about 20 times the risk in the normal population. Thromboembolism may be related to clozapine's effects on antiphospholipid antibodies and platelet aggregation. Usually, in patients who are started on clozapine, once again, there are many factors: the sedation, the sedentary lifestyle, the obesity that it causes, the hyperprolactinemia, and sometimes in schizophrenia, many times we see the patients are smokers. All these factors combined can contribute to thromboembolism. The most famous side effect of clozapine, the agranulocytosis, is a potentially fatal condition, and regular monitoring should be done for a patient on clozapine. The risk for agranulocytosis increases with age and is higher in women. Initially, when starting the treatment, the absolute neutrophil count should be more than 1,500. And in patients who are already diagnosed with benign ethnic neutropenia, we can start with a neutrophil count of more than 1,000. But the prior diagnosis should be established that the patient is suffering from benign ethnic neutropenia. Monitoring is done weekly for the first 6 months, and then every 2 weeks for the second 6 months, and monthly after 1 year of treatment. Currently, the guidelines say that any sign of an infection is an immediate indication for WBC count, particularly during the first 18 weeks of treatment. Any sign, any fever or other signs, we should do a WBC monitoring at that point only. In patients who have once developed agranulocytosis on clozapine, it is seen that after re-exposure, almost all of them once again develop agranulocytosis. So as we saw earlier, the contraindications. Once we have seen the side effect, we should not do any re-challenge for clozapine. Some other hematology side effects are also seen, like leukocytosis, eosinophilia, leukopenia, neutropenia, and overall decreased TCP along with thrombocytopenia. The total eosinophil count rises above 4,000, clozapine should be discontinued, but it can be, in the case of eosinophilia, it can be restarted if the eosinophil count falls below 3,000. Now, lithium is known to increase the neutrophil count. So in patients who do develop neutropenia on clozapine, we can start a combined therapy with lithium to further increase the use of clozapine and not immediately stop clozapine. 1/3 of patients who stop clozapine because they develop neutropenia or agranulocytosis will develop a blood dysuria on rechallenge. So we can attempt to continue clozapine for some time by using lithium along with it. The benign ethnic neutropenia is a condition, hereditary condition, which the neutrophil count is already relatively low. So as we saw earlier, 1,000 is the neutrophil count which we should consider for BEN. So lithium increases the neutrophil count and total white cell count, both acutely and chronically. So as per the Maudsley guidelines, when we have to start a treatment re-challenge with clozapine, first we have to refer to a hematologist to see if the patient is suffering from benign ethnic neutropenia, and diagnose the patient. We should discontinue any other drugs that are known to cause bone marrow suppression. Baseline investigation should be done, and a lithium dose of 400 milligram daily, which can be titrated to achieve a plasma level of more than 0.4 millimole per liter. We can give lithium. While giving lithium, we should once again monitor the patient for the side effects of lithium as well as clozapine, and the constant monitoring of agranulocytosis and neutropenia should still be continued. Sir, in patients who have developed neutropenia, and when we re-challenge without any other therapy, without lithium, we see that almost all of them once again develop neutropenia. अगर सर डिस्टेंट केस है एंड वी हैव सीन a fast response of clozapine एंड we ऐसी कंडीशन है कि हमें क्लोजापिन ही देनी है बाद में, तो लिथियम के साथ एक अटेम्प्ट कर सकते हैं by keeping the neutrophil count in check. When there is a known fast response, clozapine is the only option that we are considering for now. Hypersalivation is a very important and common side effect of clozapine. It is the excessive pooling of saliva in the mouth and drooling, particularly seen at night. The problem tends to occur in the early stages of treatment and is dose related. Hypersalivation is found to be more common in the prescribed doses of clozapine rather than low doses, and to be associated with the elevated plasma clozapine concentrations. So the higher the dosage, the more probability of hypersalivation. Yeah, it can be potentially life-threatening if it causes aspiration pneumonia. So use of muscarinic agents can be used, but there is another risk of any potentially life-threatening side effects. Clozapine already causes constipation, gastric hypermotility, and any anti-muscarinic agents that we give for hypersalivation can also cause gastric hypermotility. So it can contribute to the constipation that clozapine is already causing, and can worsen the side effect. Other non-drug treatments can be used: chewing gum during the day, elevating pillow, placing a towel to prevent the soaking. The non-pharmacological treatments. Convulsions, a very common side effect of clozapine. Yeah, it is related to dose, plasma level, and rapid dose escalation. We can consider prophylactic antiepileptics like topiramate, lamotrigine, gabapentin, or valproate if the patient is on more than 500 milligram dose per day or with a higher plasma level of more than 500 microgram per liter. After a seizure, we can withhold clozapine for 1 day and restart it at the half of the previous dose and give an anti-seizure medication along with it. Nocturnal aneurysm is seen with clozapine. It can occur at any time and at any dose. It can resolve spontaneously, but can also persist for a longer time. It affects around 1 in 5 people, or 20% of the population. Non-pharmacological treatment can be given by manipulating the dose schedules, by avoiding fluids before bedtime, and psychoeducating the patient regarding a scheduled nighttime toiletry. Gastric hypermotility is a very common adverse effect seen in more than 30% of the patients on clozapine. The mechanism of action is not understood, but it is due to the drug's anticholinergic and antihistaminergic properties. It slows the transit time through the gut, and the mean transit times are 4 times larger than normal. 80% of the clozapine patients show reduced transit times than the normal person. The clozapine-induced constipation is much more common than the dysgeusia, and also the mortality rates by the constipation are higher than they are with the agranulocytosis or with the neutropenia. The case fatality rate with the constipation is around 20 to 30%. And any gastrointestinal history and abdominal examination is recommended for any patient of clozapine. Older age, male sex, higher daily doses have been proposed as a possible risk factor for death. A slow titration can reduce the risk for developing constipation. Those increments should not increase 25 milligram per day or 100 milligram per week. Increased dietary fiber intake to at least 20 to 25 gram per day can increase stool weight, but can also decrease gut transit time. If fiber intake is increased, we should be careful that fluid intake is also increased along with it, so that in any case, due to hypermotility, large bulk of stool can be formed, and that can again contribute to gastric obstruction. In nursing care, stool charts can be used for the first 4 weeks so that it is monitored if any constipation is developing, and we can treat it earlier. If there is any change from usual baseline bowel habits of fewer than 3 bowel movements per week, an abdominal examination is indicated. Other adverse effects that are seen are sedation. Sedation can be seen in the first few months, and sometimes it wears off as the treatment goes on. Sometimes it can persist. Smaller doses in the morning and a higher dose at night time can be done to prevent any sleepiness, daytime sleepiness. Weight gain is seen with clozapine as it is seen with many other second generation antipsychotics during the first year of treatment. Dietary counseling can be given and no other non-pharmacological interventions. Very commonly, in our wards in the patients who are on clozapine, we use the Glasgow antipsychotic side effect scale it is a subjective scale that the patient can use to tell us about the side effects that he is experiencing. So that as we are titrating the dose, increasing the dose on a daily basis, we can monitor if there is any side effects occurring. The Glasgow antipsychotic side effect scale has 16 points. Most of the common side effects of clozapine, and the person subjectively takes if he gets them never, once, few times a day, every day. And there is 4 points are there for any other side effects that are not generally reported with clozapine. We can add up the points, and then as per the results we can know if there how much side effects are occurring and what is exactly is the current status of the patient, and make a decision whether to titrate the dose further, to decrease the dose, stop the drug, or to continue the drug. In case a decision is made to change a patient to different antipsychotic, it should not be done abruptly unless the contraindication agranulocytosis develops. For agranulocytosis we can abruptly discontinue. For other side effects, the sudden discontinuation has sometimes led to severe exacerbation of underlying illness. The potent antimus It is a potent antimuscarinic agent, and a sudden withdrawal can lead to cholinergic rebound, such as symptoms with nausea and vomiting. Drug interactions, caffeine. So clozapine undergoes caffeine N3 demethylation, which is a measure of CYP isoenzyme activity. It causes accounts for around 70% of variance in clozapine clearance. So any drug like fluvoxamine, which is a potent inhibitor for CYP1A2. So CYP1A2 is responsible for 70% of clearance of clozapine. And when fluvoxamine, it inhibits this enzyme, the clozapine clearance reduces. So the levels of clozapine in the blood increase, and increased concentration can cause toxicity. Cimetidine, SSRIs, tricyclic antidepressant, valproic acid also decrease clearance through inhibition of CYP1A2 and CYP2D6. So if we have to give this drug, we have to reduce the dosage a little bit. Phenytoin and carbamazepine induce the enzymes CYP2C, CYP3A4, and hepatic isoenzymes, and they decrease the concentration of clozapine in the blood because they induce the enzyme that metabolizes clozapine. So if we have to give the clozapine along with these drugs, phenytoin and carbamazepine, we have to reduce the doses a little bit. Thank you. The references were from the comprehensive textbook of psychiatry and Maudsley's guidelines. I believe this. So 10. Contraindications with absolutely. Uh, more than 500 mg. Or, like, second condition. So the next one, I need to be in neutrophil count to 1000. TL, so 3500. 1500 normally blind testing to be 1000. So, so for WBC counts, rechallenge can be done once it's increased more than 3500. For neutropenia.
स्टॉप कब करनी है और उसके बाद एक वो है कि आपको डेली डब्ल्यूबीसी जो है वो चेक करना है डेली आपको दोबारा चेक करना है कि वो एक लेवल के बाद स्टॉप करना है 1000 पे है बहुत सारा डाटा है स्पेसिफिसी पे ये काम भी कम तो हो ही जाते हैं पेशेंट्स के वो बहुत बार बिनाई निकलता है फिर ठीक हो जाते हैं और यू डिडंट मेंशन अबाउट प्लेटलेट्स आल्सो प्लेटलेट्स का क्या होता है फिर उसका क्या कुछ करना है क्या आई अंडरस्टैंड मगर इतना सारा लिटरेचर है अगर पूरी सिटी की और पूरी मौत का करेंगे तो लगभग कवर हो जाता है ठीक है अगर आपको कहीं भी कुछ मिस कर देंगे तो कोई ना कोई और नए में बता देंगे तो ऐसे फिर तो हम साइड में भी कुछ पता नहीं आता है कि कोई छोड़ देते हैं बट ऑल द बहुत ही बिनाइन रियली तो कम होता है ब्लड प्लेटलेट बट आपको एनीवे प्लेटलेट कुछ थ्रोम्बोसाइट भी नहीं होता लेकिन मतलब आपको डब्ल्यूबीसी का क्या करना है ये तो पता होता है कि आपको काम करने के बाद नेक्स्ट क्या करना है अगर आपको किसी देश में कमाया, कितने कम पे क्या करना है, कितने कम पे मॉनिटरिंग इंक्रीज करनी है, ठीक है। और तब बिल्कुल ही स्टॉप कर देंगे कि हम एक नॉट सर्टिस डिक्लेयर करें। सो डब्ल्यूबीसी का 3500 से कम होना एक नॉट सर्टिस नहीं हो जाता। एक नॉट सर्टिस की डेफिनेशन है कि इससे कम न्यूट्रोपिनिया, न्यूट्रोफिल्स आपका एक नॉट सर्टिस हो गया, उससे पहले न्यूट्रोपिनिया रहेगा। तो न्यूट्रोपिनिया क्या है और एक नॉट सर्टिस क्या है, दोनों डिफरेंट। इसमें 500 है। अब ड्रग कब स्टॉप क्या फाइव है, मैं बहुत बताता हूँ, बट यू मस्ट बी श्योर कि मतलब बुक्स में जो है अपनी ये एक नॉट सर्टिस है या ड्रग स्टॉप करनी है। पूरा प्रोजेक्ट है पूरा
regardless of the recovery also then moderate in the gambling cytopenia clinics like we see between 2000 or ANC between 1500 and 1000 so that interrupted but the patient will be likely because of the critics for to clozapine may occur once the WBC is at least 3500 and the ANC is at least 2000. These patients require weekly monitoring for a year after the reinstatement of therapy. Subsequently, sequential monitoring is reduced to every week for 6 months and is reduced every 4 weeks. The granulocytopenia, leukodemia are severe, WBC less than 2000 or ANC less than 9,000. The patient should not be gradually challenged with therapy in the future, regardless of WBC needs.
अगर 2000 पे है तो आप ये कर सकते हैं, या फिर 1000 और 1500 के बीच में ANC और 1000 से कम
ANC less than 9,000 or WBC.
और देखते बिना निकलेगा तो दिस क्या है नोट ऑफ नंबर्स और अलग से है कहीं ऊपर है कहां पे करो
This is due to the genetic issue.
तो इसके ऊपर होगा, इसी के ऊपर या कहीं पे
Clozapine should be able to WBC of 11,252 for an ANC of 11,352 for WBC 23,000 to 2,400 for the ANC from 15,000 so that it may be continued with the potential WBC so the WBC remains greater than 3,500 and the ANC remains below 2,000 in the first 6 months of clozapine treatment and
हम 3500 से कम है, लेकिन अगर 20% का है तो अगर 30 का करके वो टेस्ट की प्राइस की अगर वो 3500 से ऊपर है तो कम हो जाता है, कॉपी करनी
clozapine therapy should be discontinued whenever the patient has some content and ANC also. और इस प्लेन का जो 3000 से कम हो जाए और ANC between 100 to 1000 the clozapine treatment may be interrupted but the patient may be restarted with clozapine. And now, following the moderate I have taken
नॉट even 3500 से कम है तो हम लोग सिर्फ वो करते हैं टोटल यूज अकाउंट लिखते हैं और 14 एब्सोल्यूट सॉफ्ट। वेल से वेलकम सीबीटी करवाते हैं आप लोग, मतलब आप सीबीसी से हैं या टीएलसी है? सीबीसी पे तो मतलब एएनसी परसेंटेज में आता है, वो तो एग्जैक्टली होता है। तो आपका फिर अगर कुछ भी तो एब्सोल्यूट टोटल काउंट होता है कितना, उसके बाद सारा कुछ करने से एब्सोल्यूट टोटल काउंट होता है। तो अगर मतलब 3500 से डब्ल्यूबीसी कम आते हैं, अगर आप इसमें सीबीसी में टीएलसी कम आता है, टीएलसी तो होता है, टीएलसी अगर कम आता है CBC तो आपका एब्सोल्यूट काउंट करवाना, तो आगे उससे करना है। अगर वो 1500 से ऊपर है then it's not that a problem, but you need to multiply by 20, but it goes below one problem.
ठीक है। और 3500 WCC 2000 ANC at the time.
That you have to draft and calculate it for all. आप नहीं against the आपने देखा तो
Suspected myocarditis.
करते क्या है, मान लो एकदम से हो गया, डिटेल कम हो गया तो क्या करोगे? एक बार थोड़ा सा डेफिनेशन आया है, आप लोगों को भी डेफिनेशन आप लोगों को बताई नहीं है, मतलब तो नहीं है, लेकिन एक बार थोड़ा सा होता है वो जरूरी थोड़ा है, इसको क्लोजर पेन पे एक बार थोड़ा सा जैसे मेडिकल टर्म नॉट रिलेटेड टू क्लोजर पेन। ओके,
300 randomly.
टेस्ट होता है ठीक है, और टेस्ट होता है क्लोजर स्टार्ट करने का टेस्ट होता है, स्टॉप करने का टेस्ट होता है। एक बार तो इसका डेफिनेशन देखना, और अगर होता है तो क्या करना है, मतलब इस है कि पेज में थोड़ी सी बता दो, तो थोड़ा बंद करने के बाद तो ये बचेगा। you need to start, मतलब you need to subtle the movement, तो आप स्टार्ट करते हैं, आप दोनों इलेक्ट्रॉन और स्टिमुलेटिंग फैक्टर कौन सा स्टार्ट करते हैं? जब फर्स्ट पेज मिलेगा तो आप एक्चुअली हमें ही बताना पड़ता है कि ये करते हैं, हम तो ये लिखा हुआ होता है, फिर वो कर देता हूँ, हमको थोड़ा याद, मतलब वो फिल कस्टम देते हैं, ठीक है, लिखा है कहीं पे फिल कस्टम देते हैं, तो हम उनको बोलना कि वो अपने हिसाब से स्टार्ट कर देते हैं। बट हम अपना सेफ्टी के लिए लिथियम पे दे देते हैं, वैसे रोल ऑफ लिथियम एक साइटोसिस
lithium itself has the property to form you causing you to
ठीक है, it has no role in electrolysis, it has only neutropenia, that's why you need to very clearly neutropenia कब है और एक का प्रोड्यूस होता है, absolutely not होता है लिखा है। gastric hypomotility calculus प्राइमरी एंटीकोलर्जी से ही है, अब इतना कंफ्यूजन ये कॉज क्या है और उसको कैसे ट्रीट करते हैं, आपको बताया कि वो फाइबर इनटेक और क्या क्या करते हैं।
Or Senna, and so it's like
क्या नहीं देता
क्या
कौन हिसाब ठीक है, नहीं करना अच्छा अच्छा But constipation is not an indication of stopping clozapine, but you have to be careful and treat that. तो constipation तो मतलब बहुत कॉमन है, 30-40 मिनट में हो जाता है, 40 मिनट में हो जाता है, 10 मिनट तो, लेकिन सोचते हैं तो नहीं, आप लोग को मॉनिटर करना, जस्ट पूछना इम्पोर्टेंट है, और उसको नहीं बेटी आप लोग और हो या यहाँ पे नहीं तो फिर बाकी सब तो सारे बैठने वाले भी दे देते हैं अवेलेबल। I do not know. I do not know. You read it. There is any specific indication of closure that you go to other people. So you read it and that is not exactly how. Also, my last temper, certain type of stuff, last is that.
Half of the dose. More than 48 hours. If more than 48 hours, the retitration is done from 12.8. If it is used for more than 48 hours, retitration for from 12.5 milligrams. If only one day has been skipped, then you can serve half of the dose.
टारगेट इसका इसका ट्रीटमेंट क्या है?
For a patient who's already on antipsychotics, and some sort of psychosis has been is present, so we need to discontinue the older antipsychotic that is currently going on. Clozapine becomes the treatment of choice because both it also helps in the psychosis.
तो आपने प्रेजेंटेशन से लगा था कि मैंने डायरेक्ट इसको जो है तो प्रोडक्ट देख ही नहीं है, ऐसा नहीं है कि तो देयर आर टू थ्री थिंग्स जो हमें पहले करनी है इफ दे फेल और इफ देयर इज अ केस कि साइकोसिस ठीक नहीं हुआ है, ठीक है, तो मतलब ठीक है प्रोडक्ट नहीं ट्रीट कर सकते, बट नॉट इन एवरी केस ऑफ डायरेक्ट डिस्चार्ज प्रोडक्ट इज नॉट ट्रीटमेंट। आपको पहले एंटीसाइकोटिक डोज कम करनी है, ओके, देन you आपको एंटी पार्किंसन एंटी डोज कम करनी है, then you need to consider say diagnosis, maybe then you need to Damini, then recommendation, all things fail, and then you need to consider something. But one can be considered earlier if psychosis has not responded to the previous end. So do not consider treatment of choice or started this therapy itself. बहुत ज़्यादा कुछ नहीं है। ये मतलब मैं पहले करा था, मैं प्रेजेंट इसमें करा था, started इसमें तो बहुत नहीं